And now we are going to jump right into our next presentation on diagnostics. For those of you who are just now joining us, I am Dr. Jim Holmes, president of SAEM. SAEM is the premier international organization representing researchers and educators in emergency medicine. In our work, SAEM promotes and facilitates scientific discovery, educational innovation, and the professional and leadership development of our members. Today, we are proud to bring you a special session on COVID-19 diagnostics, the presentation entitled Diagnosis of SARS CoV-2, an Update. During this presentation and during our question and answer session, you will hear from Dr. David Persing, Executive Vice President, Chief Medical and Technology Officer, Cepheid. He will share his experience with the COVID-19 pandemic, providing along the way guidance and insight that will likely prove invaluable to the rest of us as we care for our patients in our EDs. During the presentation, you may submit questions for the presenters by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our question and answer session to start immediately after our presenter has concluded. We also want to recognize a couple of experts that are joining us online behind the scenes and will be helping to answer questions throughout the presentation. We have Dr. Patrick Mahar and Dr. Dennis Shia. Thank you all for your time and expertise. It is greatly appreciated. To begin, I'd like to introduce again Dr. Rich Rothman, SAEM's COVID-19 Planning Chair, to provide the opening remarks. Dr. Rothman is the Executive Vice Chair in the Department of Emergency Medicine and Professor of Emergency Medicine at Johns Hopkins Medicine. Welcome again, Dr. Rothman.
Thank you, Dr. Holmes, and thank you again to SAEM for hosting today's special address. Soon you'll hear from Dr. David Persing, who is the Executive Vice President and Chief Medical and Technology Officer at Cepheid. Dr. Persing was appointed in 2017 as the Chief Scientific Officer for Danaher Diagnostics platform. He spent most of his 25-year career in biomarker discovery, translational medicine, and innovation in the diagnostic space. As the Chief Scientific Officer for Danaher Diagnostics, he has the responsibility for providing scientific, medical, and strategic input to the diagnostics operating companies and platform leadership. He also has responsibility for development of new clinical processes, technologies, or products that advance patient care and innovation as part of the diagnostics group of operating companies. Dr. Persing joined Cepheid in 2005 and has focused on the enablement of molecular diagnostic technologies to meet global needs in infectious diseases. He's conducted his scientific medical training with Dr. Don Ganem and Nobel laureate Harold Varmus at the University of California, San Francisco, where he earned his MD and PhD. Since completing his residency training in clinical pathology at Yale University, Dr. Persing has held leadership roles in both academia and industry, beginning in the early 1990s with the design, implementation, and operation of the first PCR reference laboratory at the Mayo Clinic. His interest in the democratization of molecular diagnostic methods has been longstanding, starting in 1993 with his first publication of the original widely adopted textbook, which included PCR protocols and guidelines for laboratory operations. Dr. Persing has published over 300 peer-reviewed articles and reviews, including multiple articles in the New England Journal of Medicine, Science, and PNAS, and he's also served as editor-in-chief of 5 highly regarded textbooks, the most recent of which was published in 2016. In order to maintain a connection with the latest trends in translational medicine, Dr. Persing also currently serves as a consulting professor of pathology at Stanford University School of Medicine. Over the past few months, Dr. Persing has played a leading role in helping develop and mobilize molecular testing capacity across the US and was responsible for development and deployment of the first FDA-approved point-of-care COVID-19 test here in the United States. We're happy to have him here to join us to share his experience and expertise with us in the midst of this evolving pandemic. Thank you, Dr. Persing.
Wonderful. Thank you, Dr. Rothman. With that said, let's welcome Dr. David Persing. Dr. Persing, thank you for joining us today. We are very appreciative of your time, and we look forward to your presentation. The floor is now yours.
Okay, thank you for the introduction. I'm happy to be here. Just wanted to give a brief mention that, in fact, I really appreciated the mention in the last presentation about making the invisible visible, because in fact, that's what we do in vitro diagnostics. We make the invisible visible. And I think that's really playing an incredibly important role right now in the management of COVID because of the way patients present. Sometimes they can be asymptomatically infected, and it's critical for in vitro diagnostics and diagnostic approaches to make the invisible visible in these scenarios in order to really understand the disease better and to understand transmission risk better. This is a snapshot of the Johns Hopkins dashboard for cases as of last Monday, and the number, as you can see, is rising rapidly. Number of deaths is now higher than some of the earlier estimates that were probably too conservative. We've pushed above 80,000 deaths in the U.S., and so it's not going away anytime very soon. Next slide. The culprit here is a new coronavirus. It's called SARS CoV-2. It is an interesting virus. It's zoonotic, which means it has its origins in other animals. The first reported case was on December 12th in Wuhan, China, although there are reports of potential earlier cases than that in November, possibly even October. But the first reported case was on December 12th. We know coronaviruses in our recent history because of the SARS outbreak and the MERS outbreak, both of which occurred in the past 18 years, over the past 18 years, starting with SARS coronavirus, the original SARS coronavirus in 2002, and a MERS coronavirus outbreak in 2012. But we also know that coronaviruses can cause common cold symptoms. And there are 4 major strains in circulation that produce seasonal presentations of often and probably usually non-febrile presentations of the common cold. And these have an interesting history, which I'll talk about in a minute. Next slide. So if you look at the genetic relationships of different coronaviruses, you see some interesting patterns here. There are 4 different families of coronaviruses: alpha, beta, gamma, and delta. The beta coronavirus family is the most diverse in terms of having the most branches and offshoots. And these largely relate to the animals that they have come from and the animal reservoirs they have come from. And they also contain, the beta coronavirus family contains the current coronaviruses of pandemic concern or epidemic concern. SARS, the original SARS virus, SARS-CoV-2, the current virus, and the MERS family of coronaviruses. And a fair amount is known about the animal reservoirs of MERS coronavirus, but we're still trying to understand the origins of SARS coronavirus and SARS-CoV-2, although we strongly suspect that they have originally a bat origin. The bat was the original source of both the original SARS strain and SARS-CoV-2. Next slide. So looking at the seasonal coronaviruses, there are 4 major strains, as I mentioned. It's the second most common cause of upper respiratory infections after rhinoviruses. And they are clinically very difficult to distinguish from rhinovirus infections. Interestingly, these strains probably, I'll take the next slide, probably entered the human population starting back in the 1100s with the introduction of coronavirus NL63. So the 4 strains that are now endemic that cause seasonal coronavirus, seasonal common cold symptoms, probably entered originally as pandemic strains and then adapted over time to become less pathogenic. And so they're NL63, 229E, OC43, HKU1. These are now in circulation as seasonal coronaviruses, not very pathogenic, but they probably took a leap from their original animal sources as far back as the 1100s. How do we know this? Well, there are ways to do sort of molecular clock analysis in viral evolution. And if we look at the rate of change over time in the viral genomes, it allows us to project back in time to the closest relative in nature that we know of now. And so based on these molecular clock analyses, we think that the first entry of a seasonal coronavirus happened back in the 1100s, possibly from a bat origin. We think that 229E may have come through a camel intermediate host, originally from a bat. OC43, not clear bat origin, but it's also a beta coronavirus. It may be traceable to ruminant sources. And then, of course, the Wuhan coronavirus, we think originally came from bats, may have had intermediate host, and then made the leap to humans. So next slide. So SARS and MERS are the most recent coronaviruses prior to this one. And we've learned a lot about the pathogenicity and the transmission pathways of these viruses over time. But they are only partially predictive of what is happening now with the current coronavirus. The original SARS coronavirus in 2002, we think made the jump between bats to civets, which is a cat-like animal, and into humans. And it produced a local outbreak that actually went international into sites outside of China, produces outbreaks in Canada. It had a very high case fatality rate of around 11%. And so much higher than the current case fatality rate for the current coronavirus, SARS CoV-2. MERS actually has a higher case fatality rate. It emerged in 2012 in Saudi Arabia. It comes from exposure to camels. Camel spit, camel urine can lead to transmission. So be careful next time you take a camel ride in the Middle East. That's where it comes from. It's produced regional epidemics, regional outbreaks, but not widespread international outbreaks, but has an even higher case fatality rate of 34%. Next slide. So I was asked by Rich to talk about the laboratory diagnosis of SARS-CoV-2, and I'm going to be touching on serology, antigen detection, and nucleic acid amplification tests as 3 different approaches. I will not be talking about viral culture or antibody neutralization assays, which are also laboratory techniques, but not commonly implemented or widespread. So the tools that we have currently available for making the diagnosis in the emergency department at the hospital level include serology, antigen detection, and nucleic acid testing. Next slide. So starting off with serology, what's the utility of a serologic test in diagnosing coronavirus infection? One of the original findings in studies in China was that When molecular methods from various upper respiratory sites when results from the early PCR studies were completed, they were finding a relatively high rate of false negatives as defined by SARS CoV-2 case definition. So these were patients who were almost certainly SARS CoV-2, but coming into the hospital when respiratory samples were taken from the upper respiratory tract or the oropharyngeal area, they were sometimes negative. And in fact, false negative rates as high as 30% were seen in some studies in China. And so there's been an interest in complementing this false negativity of molecular methods with serologic methods. And the first point I will make, though, is that many of these early studies were based on molecular tests that were not very sensitive. They were widely available in China early on as a very strong participation in commercial supply of various PCR kits, but they were not all validated methods. And when more sensitive PCR methods were used, the false negative rate dropped dramatically. And I would say in the US, with the currently available molecular approaches in general, especially the ones that have been validated for their sensitivity, the false negative rate of molecular methods with a well-collected specimen, and I'll talk about that in a minute, with a well-collected specimen and a sensitive molecular test, the false negative rate is much lower. Recent studies at Stanford suggest that it's maybe closer to 5% than 30%. So the driver to complement molecular methods with a serologic method based on clinical suspicion I think, should be lower. And we'll look at the role of serology in acute case management and also in follow-up testing in a little bit. It's also going to be useful for identifying convalescent plasma donors for potential plasma therapy in the future. We need to know what the seroprevalence rates are in the population to know what our level of potential existing protection might be against future challenges or exposure overall. We're going to be looking at seroconversion as a function of vaccination. And some countries have talked about using serology as sort of a COVID passport. So if you're IgG positive and your IgG response is characteristic of a neutralizing antibody response, as will be characterized for many serologic methods, then there's talk about the possibility of using this as sort of a passport for allowing people to go back to work or to re-enter relatively high-risk areas with lower risk of disease transmission in seropositive individuals. This is still very much a work in progress, and we're still struggling to define what that looks like in the US because of the just very recent implementation of serologic methods. But the challenges are that these tests are not really very useful for acute diagnosis. There are too many false negatives to be practical in terms of making the diagnosis. And because of the lower false negative PCR rate with newer methods on well-collected specimens, the need for them in the acute setting, I think, is diminishing. And this is largely related to the fact that it takes a while for antibodies to develop in this condition, especially if the condition is mild or asymptomatic. It takes a long time for antibodies to develop. There's also a big problem, especially with the lateral flow technologies, the rapid antibody tests with false positives, because these tests tend to cross-react with rheumatoid factor, which is a common confounder of IgM-based serologies. and also possibly with other coronaviruses, including some of the endemic coronaviruses. So cross-reactivity is a problem, and you'll see in a minute that, in fact, that has been documented with many of the lateral flow immunoassays, which makes them less useful because in many places, the rate of false positives on those assays may well exceed the actual number of true positives in many settings where prevalence is low. So next slide. And just for your information, I've attached the references to each of the studies that I'm citing and the references to some of the information being shown in the slides. Those are at the bottom of the slide deck. So if you want to look it up and read it in detail, it's available to look at. Most of the immunoassays now are based on two proteins. There are other proteins that are being looked at, but the widely available immunoassays are based on either nucleocapsid on the inside of the virus that wraps up the nucleic acid, or on the spike protein. The spike protein's on the outside of the virus, and in fact, it's the namesake for coronavirus because it gives the virus a crown-like appearance with all the spikes on the outside. There are two major formats of this, lab-based immunoassays, fluorescence immunoassays, enzyme-linked immunoassays. These methods are proving to be the most accurate. They have the highest sensitivity and, importantly, the highest specificity. They're not confounded by cross-reactivity with other coronaviruses or as much by rheumatoid factor. The lateral flow immunoassays are fast, but they're quick and dirty. They have problems with both sensitivity and specificity. In general, antibodies are reliably detected in 10 plus days post-symptom onset. So given the fact that the average incubation time for this infection is around 5 to 6 days, with 95% of patients experiencing symptom onset within 12 days, it just takes a long time post-exposure to seroconvert, and thus they're not that useful in the acute setting. Next slide. This is some of the data that's coming out of these seroconversion studies. On the left is a JCLIN micro paper showing antibody responses to nucleocapsid at the IgG and IgM levels, and antibody responses to the recombinant spike protein on the right side. And you can see they look pretty comparable. The recombinant spike protein may have a little bit of a sensitivity advantage because it may be an earlier response, but in both cases, it takes about 10 days before you see a majority of cases that have seroconverted, and about 17 days to get the vast majority of individuals in case-defined COVID to be detectable by IgG responses. IgM responses generally, as you may know, in the literature are the first antibody class to develop in response to a new infection. But ironically, there hasn't been as much of an advantage, a time advantage for IgM in many of the serologic tests that have been looked at right now. And we don't really know why that's the case. Typically, you get a much earlier IgM response than IgG, but most studies are showing that they come up about the same time. And this is evidence in this study, and many other studies are now being conducted. A very good paper on the indicated on the right side is a study published in Nature of the natural history of coronavirus infection in cohorts of patients in Germany, where they actually did molecular testing, they did serologic testing, and they also looked at recovery of live virus from patients during the course of infection. And what's interesting about this is that the number of positive cultures drops off dramatically with seroconversion. So patients may still be PCR positive at time points. You can see at the bottom the days after onset. They may still be PCR positive at day 10, for instance, and their seroconversion may be close to 90% at that time, right? 85 to 90%, 100% by day 14 in this study. But their rate of recovery of virus seems to drop off after the major inflection point for seroconversion. So this would suggest that they are developing neutralizing antibody responses that are preventing the virus from being recovered in culture. Studies like this need to be conducted for us to fully understand the relationship between seroconversion and virus neutralization. And it'll be important for us to be able to interpret our PCR results, especially in patients with prolonged viral shedding, in light of the seroconversion data to know who's at risk for further transmission. Next slide. So we also have found in the literature that, and in published literature, is that the level of the serologic response, again, against either the spike protein or the nucleocapsid protein, or at the level of virus neutralizing antibodies, is relatively delayed in patients who have a milder course. So this has been a consistent finding. The more severe the infection, the greater the inflammatory response, the greater the recruitment of immune response cells, T cells, macrophages, et cetera, to the site of infection, and therefore the more efficient seroconversion in more severe cases. Whereas cases who are milder tend to have delayed responses, and we really don't know what the kinetics are like in patients who were asymptomatically colonized with coronavirus, but it's likely they're going to take longer to develop antibody responses than a patient who presents with more severe symptoms. Nonetheless, all the patients in these studies so far have seroconverted, whether mild or severe, by between 13 and 21 days after onset of symptoms. So it might be the case that asymptomatic carriage might take a little longer than that, but nonetheless, it seems likely that even those asymptomatic carriers will eventually seroconvert. Next slide. So a lot of the assays are being developed on the basis of spike proteins and nucleocapsid proteins. This is a structure of the spike protein that you can see, and there's the green box there is called the receptor binding domain. That can be expressed efficiently in recombinant form for the immunoassays to be developed. On the left side of that box, picture of the protein, is the SARS CoV-2 specific domain. On the right side, and the so-called S2 domain of the protein, those parts of the protein are less specific to SARS CoV-2, and so there's a greater potential for cross-reactivity with seasonal coronaviruses, and that's what you really don't want in a serologic test. You want it to be specific for SARS CoV-2. And so most of the immunoassays in development now include proteins on the left side that are more SARS CoV-2 specific. Next slide. And this is borne out by the studies so far. There's a little bit of cross-reactivity between the original SARS virus and SARS CoV-2 with the spike protein immunoassays. This is not really a practical limitation because the original SARS virus from 2002 is not in circulation. So even if there is a little cross-reactivity with that virus, what matters is that it doesn't cross-react with seasonal coronaviruses that are not SARS related. And the potential sensitivity advantage of using the spike protein, I think, can still be put to good advantage here, even with that limited cross-reactivity with SARS-CoV-2, with SARS-CoV, sorry. Next slide. Recent study from University of Washington group in a patient population in Idaho, where the prevalence is relatively low. They were specifically interested in looking at the specificity of these assays to see if in a low prevalence population there was a problem with false positives, which is a bigger problem in a low prevalence population than it is in a high prevalence population. And so they looked at different levels of specificity applied to the test from 99% to 99.9% on the assumption that if you test 1,000 people, that one false positive in 1,000 might be an acceptable level of specificity when your rate of infection is low. And so they looked at different levels of specificity and then looked at sensitivity performance at various time points after onset of symptoms from day 7 to day 17. And what they found was that at a specificity threshold of 99.9%, 1 in 1,000 expected false positives, that the sensitivity came down a little bit depending on the time-dependent course of seroconversion. But even at day 7, they found that 84% of cases were seropositive with essentially 100% specificity. So this is encouraging because it means that we don't have to deal with these next-gen laboratory-based immunoassays that run on big systems found in clinical chemistry and clinical immunology labs throughout hospitals in the country. These big systems will be capable of delivering accurate results that have low false positive rates and with reasonable specificity, but still not where you'd want them to be to make a diagnosis of an actively symptomatic patient presenting for the first time because of the lag time between initial presentation and seroconversion. Next slide. I mentioned rheumatoid factor. Rheumatoid factor is an anti-IgM antibody, which actually can interfere with a lot of immunoassays. And by using special techniques to essentially wash off these low avidity antibodies that don't bind very tightly to a target, but they produce non-specific binding problems, we can distinguish with some of these central lab immunoassay platforms, we can distinguish rheumatoid factor from true antibody responses by carrying out these washing steps. This is not a feature of lateral flow immunoassays. They really can't do this with the rapid fingerstick blood-based immunoassays. So they will struggle with rheumatoid factor and cross-reactivity depending on the test. Next slide. This is a study that was published recently from UC San Francisco, and on the right side you see different lateral flow immunoassays that usually run from fingerstick blood. And what you see in the panels is the performance of these assays, percent positivity from 1 to 5 days, 6 to 10, 11 to 15, and beyond. And some of them perform poorly across all time points. All of them improved in sensitivity as time went on, but very few of them performed very well in the days following clinical manifestation of infection. So you can see that even with combined IgM and IgG in the middle panels, that the sensitivity did not exceed 50% in the 1 to 5 day period. It got a little better from 6 to 10 and beyond, and got close to 80 to 90% sensitive in the convalescent phase of these infections. But on the right side, you can see the specificity of these tests when run in populations of patients pre-COVID in San Francisco. So before any exposure to the virus, they included serum banks from people who, which were available prior to COVID, that the IgM and even IgG responses had relatively high false positive rates, ranging from 5% to as much as 8% false positives for IgG, and as much as 15% false positive rates for IgM. So this is higher than the presenting rate of infection in presenting patients in many medical centers. So you could expect that if you use this test for the acute diagnosis because you didn't trust your PCR, that you'd expect to see a lot of false positives. And these would have to be resolved later with a big box immunoassay platform that would be run in the central lab. Next slide. So interpretation of these results: IgM negative, IgG negative, no evidence for prior exposure, except lateral flow tests. You might see false positives with IgM. So I'm really restricting my comments now to the next-gen serologic tests, which don't have false positive problems. And I mentioned about delayed seroconversion. If you're still concerned about active infection and the patient is totally antibody negative, then PCR is recommended, or a nucleic acid test recommended for ruling out active infection. IgM positive, IgG negative could be an indicator of early infection, especially if it's a next-gen assay that doesn't have false positive problems. You could expect IgMs, even with those next-gen assays, to have higher rates of false positivity because IgM antibodies by their nature are less specific for the target and don't have high affinity for the targets. And so cross-reactivity rates are expected to be higher. In that case, PCR will be recommended for ruling out active infection. Next slide. I think I may have skipped a slide there. There was a second. Okay, I'll just go on to the next slide. So the bottom line from serology is that it's going to be useful for epidemiologic tracing, understanding population risk. It's not that useful for the acute setting. The message that you may hear from aggressive point of care antibody marketing companies is that it's because PCR is so insensitive that you need this. But actually, I think current PCR practices, especially in the US, are such that with most of the assays out there, that we can depend on those results better if the sample collected is a good specimen. So combination of good specimen and good PCR test, good nucleic acid test, will result in very low false positive rates based on what we're seeing so far. Antigen testing, recent announcements from a couple of companies on antigen testing. We know based on flu testing that the rapid antigen tests for flu are, at least on a limit of detection basis, are about 1,000-fold less sensitive than molecular methods. And antigen testing is quick, it's relatively inexpensive, but it doesn't have the same sensitivity of a molecular method. It might be okay for an acutely ill patient with high clinical suspicion in a point of care setting, but you're still going to have false negatives just based on the analytical sensitivity differences between molecular and protein-based antigen detection. So it might be okay for identifying supershedders when you have a perfect specimen from a supershedder, but in sort of clinical actual life in a clinic where sample collection might not be perfect, might not get actually all the way back to the posterior nasopharynx, and where you have less than perfect conditions of operation of the test, then it might not do as well. Thank you. Next slide. A nucleic acid amplification test. This is the final area I'll talk about, and then finish up with a couple of notes. The nucleic acid amplification tests that are available now represent a combination of central lab, reference lab tests, central lab tests that are often now run in hospitals, and a few point of care offerings as well. The targets used for these tests vary widely. In some tests, there are 2 targets included to avoid the potential for genetic drift of the virus as it mutates. We don't want the virus to mutate away from being detectable. Some assays have 1 target, some have several targets, some have broad range targets that will cover other members of the SARS bat coronavirus family. Some are very strain specific. But in general, I would say the state of the art for nucleic acid testing is such that the major commercial suppliers of nucleic acid tests from the major manufacturers, along with the reference lab methods that have been developed, even though they're laboratory developed tests and may not depend on a commercial manufacturer, are performing at a good level. Next slide. Some of the data coming out of that paper I mentioned from Germany shows some of the PCR data. This shows the tracking of PCR results in stool, sputum, and oral swabs over time after symptom onset. So you can see that in sputum, especially in patients with lower respiratory symptoms, there tend to be pretty high levels of virus, and it takes longer to clear. In oral swabs, the greatest utility of these swabs appears to be within the first several days after symptom onset. So in this patient case study that they presented, when the patient had a cough, they were able to readily detect it in sputum and an oral swab, also in stool. Importantly, you can see that there was a seroconversion point here with the arrow at around day 9 when they first saw antibody. When they went back to culture virus from the stool and other samples from this patient, the cultures began to become negative, and they were never really positive in stool samples. So there's controversy about what a stool PCR really means. We know you can detect RNA in there, but we're not sure about whether it really represents an infection control risk, especially after seroconversion in patients who are in the convalescent phase. Next slide. Many of these tests have gotten emergency use authorization, and many of the so-called drive-through options that you see out there are run on reference labs, either on a commercial platform or a laboratory developed reference lab method. These are typically run in batches. So you collect the specimens in batches, you wait for a batch of swabs to justify shipping, you send the batch specimens to the lab, they're batched in the lab. And depending on the test, in a reference lab setting, you can expect results in 2 to 7 days, although I think that's getting faster now because of the increasing testing capacity. But 2 days is a realistic turnaround time from a reference lab. What's happening now is we're seeing a lot of commercial systems that are already in hospitals: Roche, Abbott, Hologic, BD, Thermo Fisher, Diasorin. These are increasingly available at the local hospital level, so they're closer to the patient and the results can be faster. And so this really depends on the shorter transit time of the specimen to the lab. They're still batched, but the results are faster because batches are being run frequently. These are not generally available in small to medium-sized hospitals, and they all require trained staff, and staffing of these systems around the clock has been a real challenge in the current situation. Next slide. There are some sample to answer NAATs that are available from the Xpert, the ID Now system from Abbott, and the ePlex system from Genmark. These have been compared in one study just published, and they range in sensitivity. Next slide. Their analytical sensitivity is also variable. So the number of copies of RNA it takes to trigger a positive result varies widely between these point of care options. I would say in general, though, most of the central lab methods and reference lab methods are in the 100 to 200 copies per ml range for limit of detection. So central lab testing is generally, I think, sensitive enough to be used as a gold standard method. Next slide. There are very few studies actually comparing platforms against gold standards. And part of this is because the emergency use authorization process for getting these tests on the market did not require an actual clinical trial. So Cepheid has performed a multi-center clinical trial. Other companies have done that. And we're seeing more and more studies now comparing different platforms in actual clinical specimens prospectively. And so this is very helpful to judge the performance of these tests and how they'll do in real life. And this study was just published, data is available, and against the gold standard of the laboratory developed tests, the public health lab tests, and other commercial tests, the level of performance was highly concordant. Next slide. Specimen collection matters. As I mentioned, it really does matter here. There's a lot of interest in avoiding false negatives because of a bad specimen. And I mentioned about the high false positive rate, high false negative rate in China. Part of this may relate to the fact that in China, they like to favor oropharyngeal swabs and less nasopharyngeal swabs for largely cultural reasons. And this leads to the fact that you can't get the site with the highest viral load into the test, and this may lead to a higher false negative rate. As I mentioned, the Stanford false negative rate is reportedly less than 5%. This is based on nasopharyngeal swabs being tested with a sensitive method. And I think that combination will lead to low false negative rates overall. Combining swabs, oropharyngeal and nasopharyngeal, into the same transport medium, I think could result in less sampling error, where you might miss the site of replication by combining anatomical sites in one sample. And data suggests that when you combine the swabs from two different sites, you may get better performance. Next slide. Which specimen is best? In general, nasopharyngeal is more sensitive than nasal swabs. The viral loads are higher. When compared against oropharyngeal swabs, a little bit better performance than oropharyngeal, better than nasal. But we all see that in sputum aspirates that that performance overall is high because of high titers in these specimens. A lot of interest in saliva testing. This could reduce biosafety risk during collection. It could be collected at home potentially by the patient, self-collected, not swab dependent, can be self-collected. So, and when you think about it, this could be a naturally pooled specimen, especially if it's a deep throat cleared saliva specimen. I used to say in junior high, haka loogie, right? Clear your throat, pool the specimen in your mouth and spit it out. This appears to be a way to sample the upper respiratory tract as well as the oropharynx in one collection process. So this may be a specimen we use going forward as a sort of a naturally pooled specimen to cover different anatomical sites of replication of the virus. Next slide. And this just shows some of the data on saliva, it looks actually pretty promising. And so a lot of the test manufacturers are now validating saliva as an alternative, especially in the age when it's hard to get swabs and hard to get viral transport media to do the test. This might be a nice alternative to be able to provide for specimen collection. Next slide. And it looks like actually there's more human DNA on board in saliva than there is in NP swabs, suggesting that the number of cells sampled that could be replicating virus might represent an advantage in terms of just getting more stuff into the final reaction. Next slide. What about asymptomatic carriage? A small study done at University of Washington, nursing home residents showed a pretty high rate of asymptomatic carriage in a nursing home. Over half of them were asymptomatic with pretty low cycle threshold values or pretty high viral loads. 10 of them developed symptoms within 1 week. And they really didn't see any differences between symptomatic and asymptomatic cases in a nursing home setting. They also showed that these asymptomatic cases were all, in a later publication, showed that they were culture positive when they were asymptomatic. So this represents a significant source of transmission pressure in these group congregate living situations. Next slide. Stanford recently did a study of about half of their healthcare worker population at Stanford Medical Center. They did over 5,000 PCRs. They found a 0.4% positivity rate, which I think is lower than they found at Rutgers, with about a 7% positivity rate at Rutgers. Low positivity rate at Stanford, but some of the viral loads in some of the individuals or carriers were on the low side, which means are on the high side, cycle threshold values on the low side, suggesting they might have been capable of transmitting from those cases. They also saw the first RNA positive blood donor at the Stanford Medical Center, last symptomatic in mid-March. They were antibody positive. Their plasma was positive for 2 targets, and that donor is being tracked. But this could be a new source of transmission potentially in immunocompromised patients if blood donor screening is not implemented widely in the future. Next slide. Pooling might be able to increase throughput in our testing by combining transport media into one sample and testing the pool. If you have a very sensitive PCR test, you might be able to actually do a lot of people with a relatively small number of tests. Stanford did this for looking at respiratory samples in the January-February timeframe before COVID in Santa Clara Valley. They pooled the samples into pools of 10, I believe, and they went back and deconvoluted those pools to find 2 positive patients in that time frame. So not very many cases being transmitted in the months prior to the official onset of COVID. This could be a potential approach to asymptomatic screening in lower prevalence populations, which is being looked at. Next slide. To conclude, I want to give some time for questions. I'm sorry I haven't left more time, but serologic methods are rapidly evolving, not really helpful in the acute management stage. Most of the combinations of results need to be reflexed to a molecular test anyway in the acute phase of patient management. Lab-based methods for viral serology are vastly superior to lateral flow at this point. Nucleic acid tests are the gold standard. Most of the tests on the market from most of the manufacturers and most of the reference labs are up to snuff in terms of sensitivity. But these tests are only as good as the sample that's collected. So garbage in, garbage out. If it's a bad specimen, you will not get an accurate result. So pay attention to getting good specimens. Watch for the flinch sign from patients getting nasopharyngeal swabs. They're going to flinch. I like to say for a child, you have a single lifetime opportunity to collect a nasopharyngeal swab. You will never get another one again. But I can say also that's probably true for a lot of adults. So got to have a flinch, got to have tearing to indicate that you've had gotten to the site of collection. And it's challenging enough right now outside of the respiratory season. We need to prepare ourselves for what we're going to do in the upcoming respiratory season. And I think it's good to think about that now in terms of how we manage these patients, what tests we run, how do we distinguish them clinically with laboratory methods. And I think that's going to be a big challenge in the upcoming respiratory season. That's all I had to say. Thanks.
Thank you very much, Dr. Persing, for this timely and insightful presentation. We will try to get as many questions as possible in our remaining couple of minutes. So while the questions are coming in, let me ask Dr. Persing, will we see testing widely available that would allow us to immediately screen people to meet in large groups? For instance, weddings, sporting events, academic meetings like we are having right now.
It's a very good question. There's a lot of discussion about that right now. I'd say right now, there's a lot of interest in asymptomatic testing, but that focus is primarily on the go back to work strategy for hospitals. It's based on pre-screening patients for elective surgery, healthcare workers, labor and delivery, incoming admissions, for looking for asymptomatic carriers in that setting. I think eventually we're going to see this branch out into like testing nursing homes and healthcare staff at nursing homes, and then maybe move to testing essential workers in other industries. From there, I think we will eventually see more widespread implementation of screening methods, possibly on larger populations, perhaps using a pooling strategy, which could screen a lot of people with a relatively small number of tests. But that all remains to be shown whether we can do that effectively.
Thank you very much. A question from Jonathan Rubin. How much does creation of assays under the Emergency Use Authorization Act affect test accuracy?
It's a good question. I think the amount of proof required to get an emergency use authorization depends primarily on mock clinical specimens, where you take nasopharyngeal swabs and you spike virus onto the swabs and detect the virus at different concentrations. None of the EUAs have had to depend on any kind of clinical trial evaluation. So the actual performance in the field is not really known very well. It's just coming out in the past couple of weeks in some of the studies that I cited. So it remains to be seen which ones of these will work or not work based on prospective data collection of head-to-head comparisons. But right now, the threshold for emergency use authorization has been focused on expediency and getting as many options on the market as possible, and hoping that the data coming back will allow for better understanding of how they're actually performing.
Thank you very much. A question from Michael Brown. You mentioned that the false negative rate is likely only 5% in US-based studies. What is the gold standard used to determine the sensitivity of these PCR tests?
The gold standard in that case, and I think that in most centers, is a clinical diagnosis, which often depends on a clinical presentation characteristic plus a series of tests applied to a patient over time. So for instance, a patient may come in respiratory distress, they get admitted, their nasopharyngeal swab is negative on admission, but their tracheal wash is positive. And that composite definition of a case over time after admission is what goes into the gold standard diagnosis. And so we're finding that in general, there are cases where the virus is no longer present in the upper respiratory tract. It's now concentrated in the lower tract. Those are the cases we will miss with just respiratory tract sampling. And so there is some low, I think still low probability of that, even with sensitive methods and a good sample. So it's not non-existent, but I think that ultimately the case definition with supporting laboratory and other clinical evidence is what the gold standard should be used, should be in that setting.
All right, thank you very much. Unfortunately, that's the last question we have time for today. Thank you again to Dr. Persing for sharing your incredible stories and for your helping the rest of the country prepare just a little bit better for the COVID-19 pandemic at their own hospitals. Dr. Rothman, do you have any final remarks?
Thanks, Dr. Holmes. There's obviously been a tremendous amount of research in this space in the past 2 months, and I just wanted to personally thank Dave, Dr. Persing, for consolidating and sharing this in a unified format for the SAEM audience. It's very much appreciated. I know how busy you are, and I think it's extremely valuable. And I'd just like to end with a call for the academic emergency medicine community to continue to play an active role in research through collaboration. I think we have an important function here that's going to help inform how we deploy these tests in practice, and that will end up having a big impact, I think, over time for patient care decisions in the emergency department and for the health of the public. So thanks again, Dr. Persing, very much appreciated.
Thank you very much, Dr. Rothman. Thank you again to our speakers and to all of the viewers for joining us today. We look forward to seeing you tomorrow for our next keynote address on medical education and our COVID-19 special session on therapeutics. Stay safe and have a good day.